Hi, I'm P. Michael Bratch, and today we're wondering, does Ontario have the right doctor? Dr. Colin Furness is an infection control epidemiologist and an assistant professor at the Faculty of Information at the University of Toronto. And I want to come back to why those two skills combined are important. But first, I have to ask you, Doctor. According to the Telegraph newspaper, scientists in Europe are saying that bald men versus, are more likely to die of COVID. I mean, it's something about the hormone androgen, which causes hair loss in men, being linked to some of the worst cases of COVID-19 in Spanish hospitals. I mean, is this true?
That is news to me, and that's interesting. It's not impossible, but that doesn't sound like the likeliest. I think there's a lot of reason to believe that there are genetic relationships. We have some sense that blood type matters. It's entirely possible. It's going to take us a long time to really learn the relationship we have with COVID and the various different ways that it exploits our weaknesses. So baldness could be one.
So we might see Bruce Willis, the ghost of Telly Savalas, and The Rock sheltering together.
Well, the question is, will wigs actually provide a protective effect against COVID? We clearly need to do a little bit more science there, I think.
That's great. And then, of course, the big question is, if you pull your hair out of frustration with what's going on, does that count too?
Well, I would be concerned about that because my hair is thinning, so I think I better probably pay close attention.
That's great. That's great. So now, as I mentioned at the beginning, Colin, you're both an infection control epidemiologist and an assistant professor at the Faculty of University of Toronto, at the Faculty of Information at the University of Toronto. And I know that you've been extremely busy on the media circuit, doing interviews with CBC, with the Star, with all kinds of publications. We're glad to have you here. Tell us, how are things going in Ontario specifically? And how have the communications been about what's going on? Because, I mean, for me, it's been about as confusing as trying to redeem airline points, following my instructions on what to do around COVID. What are your thoughts?
Well, my own background, as you say, combines these two different things. There's the biomedical side, but also the information side, specifically how organizations use information to make decisions. And I have been tearing out my hair. I think in raw terms, our COVID experience has been not that bad. It could have been so much worse if you look at what some other countries have faced. And I think it's important to know that. But I remain really frustrated at the decision-making process, the lack of use of information, and the lack of commitment to generate data that we could use to improve our understanding. So we have really worked very hard to keep the lights turned off, to make sure that we are tripping over as many things as we can and losing a lot of opportunities to get ahead. And I think that's what's really frustrating.
Right. And some of the things that were confusing were that I could call a housekeeper into our house and perhaps into other people's, the same person could visit other people's houses, but you can't see your mom.
Unless you pay your mom $5 to clean your house, and then it's okay. So we do
That's okay then.
think that is being made available to the decision makers and then the decision-making process. So the expertise may or may not be there, we can't tell, but the decisions themselves don't seem to reflect that kind of input.
So I guess on the bright side, unlike the orange god to the south of us, Premier Ford does appear to be following and being respectful of science. And I guess according to the Geraldton News, which is where I get most of my news, by the way, our chief medical officer, 69-year-old Dr. Williams, is somebody who is now heading the command table and giving advice to Premier Ford. But before he actually took on this role, at one time he was a general practitioner up at Sioux Lookout up north in Ontario, and he did some studies around epidemiology along the way. Do you think we've got the best guy heading up our command table here in Ontario?
It's hard to tell being on the outside looking in because I'm obviously not at the table, but there have been some things that Dr. Williams has said that I take great issue with and suggest to me that his understanding of testing strategy, his ability to deal with what is not out of the textbook, what is truly novel, willingness to generate data, to ask hard questions and then to try and answer them empirically, that seems to be missing. And so consequently, our strategy has really been out of the textbook for a different era and a different kind of pandemic. And that has really been difficult to watch.
No, that's got to be concerning. And I think obviously we've seen the most deaths at our long-term care homes here in Ontario. Yet Dr. Williams was at one time the medical officer in charge of long-term care homes.
I suppose more than most, he should have been able to see that coming. But I also have to say that long-term care homes have been a point of disaster globally. It's not an Ontario problem or even a Canadian problem. We had it particularly bad, and we took a long time to take the basic steps to fix that. I think we could have done better there.
Now, this is a chart showing how easy it is to understand the command table in Ontario. What do you think? Is it that easy to understand, and how does it compare to British Columbia?
I think you may need another table to explain this chart of tables. It is, it's complicated and it's incomplete because it doesn't actually show information flows from one to another. So I see a bunch of tables and I look at it and it feels a little bit like a bridge tournament. There's a room full of tables and there's people clustered at each table. No one can see anyone else's cards. Right. And in terms of the decision outcomes we've talked about, it's not clear to me that everyone knows the rules of bridge. So it really does look complicated and it looks inefficient. And I think some of the decision outcomes may reflect that.
Right. Well, that's great insight. I mean, yeah, it is complicated. And I see we've got 34 health boards in there, which we're going to come back to. But I mean, how does this command structure in Ontario compare, for example, with another great Canadian province in British Columbia?
I'm not expert in British Columbia's structures, but generally speaking, they have better integration between public health on one hand and acute care on the other. Ontario has those functions very separated, and there were some good reasons to separate them. But when you do that, you need to build in workflow and you need to build in communication that is effective. And we see in this table of tables or this map of tables that hasn't happened here. So I think when all the dust settles and it's time to figure out how can we be better, how can we improve, I think we should take a very hard look at BC's structure. They are a lot smaller than we are. We're 3 times the size of BC, but good organizational structures should be able to scale. And I hope we do take a good look at that.
Yeah, they're smaller than us for sure. I think the interesting thing is that on a equal basis in terms of 100 per 100,000, BC's kind of infection rate has actually been 1/4 of Ontario's infection rate.
Yeah, it's been about that, and BC has a lot of risk factors. The population's a little bit older than ours. They've got more tuberculosis, a lot more, and that is actually a bellwether of marginalized populations and population health. They have proportionately a much larger homeless population. They've got a lot of poverty. They have higher population density in Vancouver proper. There's a lot of factors you could point to say, wow, they really should have gotten clobbered by COVID. And in some senses, we could say, well, they were fortunate that some bad things didn't happen to them, but they really managed it effectively and they managed it early. And that made all the difference.
Right, and I'd add to that list of factors. I mean, the fact that Washington State was one of the early adopters, if I may say, of COVID in America, and we had all that cross-border traveling still happening, and yet they managed to tap it down pretty nicely.
Well, it's remarkable when you think that, say, on March 20th, BC had more cases than Ontario of COVID, and I'm not talking proportionately. I mean, they had more cases, so proportionately, they were way more affected by COVID. 10 days later, Ontario had twice the cases that BC did. So that last week in March was pivotal. BC diminished and Ontario took off.
That's amazing. Now, we all saw the Premier of Ontario, Doug Ford, going up to the podium and really getting quite upset, almost yelling that, why isn't there more testing going on? I want testing done. And he'd be up there day after day. And his target would shift from time to time in terms of who he thought might be responsible. But at the same time, the chief medical officer is quoted as saying that testing too widely would produce biased data, and it would skew too heavily towards negative results when the goal is to reflect the population at large. So he was almost not supportive of testing. What do you think's behind that kind of thinking or that kind of a statement?
Well, when I heard Mr. Ford shouting, I was shouting right back at the television saying, you're asking for the wrong thing. Simply looking at the numbers of tests that's an easy yardstick. The problem is that we've had the wrong strategy, and the wrong strategy does not require a large number of tests, and that's been the disconnect. And I do have to place that squarely in the wheelhouse of our Chief Medical Officer of Health and our Associate Chief Medical Officer of Health, both of whom have made statements that suggest that testing should continue to be limited. Now, let's be clear, they're not being incoherent, they're being outmoded. There's an orthodox testing strategy that says testing is a scarce resource. You use it only when you need to. You use it when you're pretty sure you're going to get a positive, and you only use it when the test result will actually dictate treatment. So if you look pretty sick, I might look at you, if I were Dr. Williams, and say, well, I'm not going to test you because no matter what it says, I'm going to tell you the same thing. Go home and eat some chicken soup. So there's no point testing you.
Wow.
That's right out of the textbook for how you apply testing and screening. But it doesn't actually work when you have an asymptomatic pandemic that is raging through the province, that is causing a lot of illness and death. What you need is a strategy called sentinel testing. And it's also in the textbook. It's just in the newer textbooks. And sentinel testing is all about going where the risk is. You test people not because they look really sick, but because they are likeliest to be sick. So in this case, we could have and should have been doing airport limousine drivers and people who work in grocery stores, people who had occupational exposure to lots of other people during the lockdown. Think about it. We locked people down to limit physical distancing, to limit physical exposure rather to each other, right? So if we can then see who's still left with a lot of occupational exposure to people. My children can understand that people who are working in stores and people who are driving taxis are going to have a lot more risk. My children understand that not everyone who gets sick and is contagious looks sick. So it's a question of connecting the dots, and the numbers don't go very high to connect these dots, to say we needed to do sentinel testing. Now we have, as of the end of May, the Premier has announced that. I've been asking for grocery store workers in particular to be targeted. That was in there. I was happy to see. Now let's go back to this question of 20,000, which seemed like this great number, is not even remotely adequate. And that's why I said this is not about numbers, it's about strategy. 20,000 is too much capacity with the wrong strategy. With the right strategy, it's not nearly enough. We might need 10 times that kind of testing capacity, because everybody who works at a cash register is going to need to be tested. And every day, more and more such people are going back to work, and more people are crowding back into stores. And we're going to see a lot more cases. You either have to lock people down or you need to test them. You've got to commit, and you've got to do one or the other properly. So far, we have failed on both. It's not too late for us to ramp up testing, and that's really what we have to see, I think, is the most urgent priority.
I see. And it's interesting to see that, Wuhan, the Chinese government decided they were going to test, 11 million residents in Wuhan, and they got a large portion of that done in very few days. And from a strategic point of view, there was a really interesting point, which is that they were actually batch testing. So they were actually collecting a group of 5 or 8 people, putting their tests all together into one batch and sending it off for testing. Hopefully they were using separate swabs, but sending it all off as a group and testing once for 8 people. If the test came back positive for COVID, then they would go back and test each individually. But I mean, strategically, that seemed to be a clever way of solving the problem of how to test larger numbers.
It's brilliant. It's formally called pooled testing. It was invented in Germany.
Right.
The idea is quite simple. The tricky thing is to mix samples together and not lose sensitivity. That is, still be able to detect virus. And the Germans figured that out. And you could, easily quintuple your testing capacity. I think 5 is the number they usually recommend. I don't know the details of how high you can go and still not lose sensitivity. Yeah. But you do that without hiring a single lab tech. And yes, if you're going to do mass testing, you expect most to be negative. We should be doing this. I haven't heard a peep that we are, but I'm going to keep asking for it because, as I say, we've only got a little bit of time before the fall, before it gets ugly. We've got to get our testing house in order.
Yeah, I mean, just taking that simple concept that the Germans seem to have developed and the Chinese are perfecting, I mean, we could potentially be testing 100,000 people per day. And that's significant in a province of 14 or 15 million people, obviously. I want to ask you, Colin, once we've done the test, then we've got this other issue of contact tracing. So, and in the beginning, again, not to pick on the medical people, but these are the people that the Premier is definitely following. The Associate Chief Medical Officer, Dr. Yaffe, actually went so far as to say that, she wasn't sure that, she said basically that information on contact follow-ups is not currently being entered into the central provincial database, but we're very confident that the contact follow-up is being done. It's a priority. And then later on, we went on to discover, that there were 700 positive cases that didn't get even entered into the system in the first place, let alone contact tracing. What are your thoughts on all of that?
The information system we're talking about is called IFIS, the Integrated Public Health Information System. And it is 12 years ago when I was working with that, it was antiquated and inadequate. You couldn't find anyone working in healthcare in the province of Ontario who would defend it in any way. That was 12 years ago. We didn't replace it because we've been waiting for a federal system. And it's the federal system still isn't built. So that's more than a decade late and way over budget. So we were sort of. I'm guessing
the federal guys are still working on payroll. They want to get that done first, the payroll system, and then they're going to focus on it.
They did, yes. Well, you know what? Same company, which is interesting. But the thing that they focused on is actually immunization. So it's ironic that we're being felled by an illness for which immunization information actually is not helpful to us. So the information system is dreadful. But the other problem is that privacy and public health are naturally on a collision course with each other. And one of the reasons why IFIS is quite dreadful is we're dealing with health information, and that is considered to be super private. We have major regulations around that. That's why healthcare still uses fax machines and telephones, because those are, in finger quotes, proven technologies for maintaining privacy. I mean, nothing is allowed to be sent by email, and I don't disagree with that. But the big problem is people can enter data into IFIS and not have authorization to see it. So it really is the left hand doesn't know what the right hand is doing, and the eyes can't see what either hand is doing. So it's extremely difficult to enable coordinated action with an information system like that, and that's tough. That's really tough. I would favor loosening privacy restrictions around healthcare data in emergency situations. That would need to be done transparently, would need to be done carefully. But when adherence to privacy impairs our ability to save lives, we've got a problem we need to solve.
Yeah, and surely we can anonymize, patient information through numbers and codes, and probably a good place to start. By the way, you mentioned fax machines. For some of our viewers under 30 years of age, this is what a fax machine looks like. And, we're the province that invented the telephone. We're the folks that invented the smartphone. We're leaders in the world. Unfortunately, a lot of our smartest minds have gone off to California and are working there. But, why is it that we can't get rid of, the medical industry in Ontario is almost the only industry still using fax machines and pagers for that matter. So it seems like a bit of a tragedy.
We do a lot of research and development in Ontario and in Toronto specifically in information technology for healthcare. A lot of it is around mobile health, which is really cutting edge. A lot of it is around better ways to make use of stored data interoperability so that a doctor can actually make sense of diagnostics from different systems, having health information available in different places. We've made progress. We've done a lot of work. But Ontario is a great place to do research. It's less of a great place to do implementation. And that gets down to money. There's no question that gets down to the money that it takes to implement these complex systems in complex work environments. We could be doing a lot better at that.
Right. And it's, it looks like it keeps getting kicked down the road from one government to the next government to the next government. And now we're in a crisis, obviously, and it would have been great to have. I want to turn finally to one other area. And, we're all excited that it's the good weather's here in Canada. Patios are starting to open up, golf courses, and in different phases we're permitted to do different things. I've heard a lot of talk about that. I'm excited about it. But the one thing that I haven't heard about is, how are we going to clear up the backlog of people who have been struck by cancer or are dealing with, requiring elective surgery and other types of surgeries. I mean, going into the pandemic, there was a massive backlog. And, I know of a 15-year-old girl with scoliosis, for example. She's awaiting surgery. She's in pain. She can't get access to her physio, her osteo, none of that. It's all shut down. And being 15, she's on her way to being an adult. And if she doesn't get the surgery done quickly, she's going to end up in the adult queue and start probably back at the beginning again. What are your thoughts finally about how the province is dealing with the backlog of all these folks that are affected?
Well, it's a serious problem. I guess what I would say is, in contrast to our public health system, which is underfunded and difficult, our acute care system is pretty phenomenal. And the one thing we didn't really get to see was the effect of how we transformed our whole healthcare system into a giant ICU. This was phenomenal. And had we had a situation like New York or Northern Italy, we would have risen to it. It was pretty amazing to watch that. And I think our acute care system is equally capable of transforming itself back. What we're going to need is money to pay overtime to get this work done. Now, operating rooms in hospitals can easily work on a 24-hour basis. They don't. They don't because of budget. They don't because of limits. But it's possible to make up this backlog. I won't say in short order. I don't want to be naive about that. But we could really put our shoulder to it and have operating rooms going 24 hours a day. Where we have some bottlenecks that we can't easily fix would be certain specialists, certain specialties where there's a shortage. So that could be a problem, for example. So it's not going to be uniformly easy to do that. But I think certainly in terms of surgeries, it's a scheduling. This is a scheduling problem, and this is a budget problem, and I think both of those are solvable.
Yeah, we've got to get all these very expensive hospital theaters, operating theaters, and these multi-million-dollar, MRI machines, et cetera. We've got to probably get them working 24 hours a day instead of just 10 or 11 hours a day, and get through it, because we had an 18-month backlog going into this thing in many cases, and obviously that's a priority. Colin, thanks so much for joining us. It was great to get your insight into what is unfolding in Ontario and overall in Canada as well. I appreciate it. It was great talking. We learned a lot.
My pleasure. Thank you.
What a great interview with Dr. Colin Furness, one of the top epidemiologists in Ontario. We've got a lot more coming, so make sure you hit the subscribe button, and we look forward to joining you again soon.